We have just a couple minutes until we get started. Hi, Elise. How are you guys? Welcome. I see all kinds of people in here. Just another reminder, you guys, we do have your microphones muted. So I'm going to repeat this over and over again. But we do have your microphones muted right now. So please use the chat box at the bottom of the screen so that you guys can participate. Hi, Giannis. How are you? All right, we have lots more people coming in. Welcome. We're so excited to have all these people here. This is going to be a really, really great experience for everyone. So stay tuned. I'm going to go ahead and get started. I'm going to give people like 2 extra minutes to jump in. So we'll go ahead and get started in about 4 minutes. So welcome, everyone. Welcome, Troy's. Oh, I thought I saw her pop in. Hi, Lee. Hey, everyone. Just for all of you guys who are just joining us, your microphones are muted. So I encourage you to please use the chat box that is available to you. There's an icon at the bottom of your screen. And if you click that, it should open a chat box that should give you access to participate and ask questions here. We will open up for questions from everyone after Dr. Johnston's presentation. So feel free to ask the questions or save them until after the webinar, and we'll go ahead and ask them. Hi, Ava, and hey, Ronan. How are you guys? Welcome. All right, what a great turnout. We're gonna give just a couple more minutes. Wonderful. Yay. As we wait for some more people to join us. Awesome, guys. So for those of you who just joined us, everyone's microphone is muted. We do have the videos on, so you guys can scroll through and look at everyone's videos. Hi, Brenda, I see you there. And please go ahead and, hi, Marty, I see you too. Use the chat icon so that you can go ahead and use the chat box and participate in the webinar. We really encourage everyone to participate. All right, wonderful. We just have a couple more people coming in. Hey, Sherry, I see you there. All right, guys. Wonderful. Does anyone have any, if you have any questions, again, use the chat box, please. I can't hear you. Hey, Matthew, how are you? Welcome. Awesome. Let's see here. Welcome, everyone. It's 4:30. I'm going to give, this is going to be exciting. I am going to give just about another minute and a half before we get started so that anyone who is coming in a little late can make sure to join us here. We do have one youth here from Argentina. Hey, Facao. Did I say your name right? No, I'm sorry. Wash out. Sure. Faku. Yes. Okay. Hey, everyone. How are you? All right. So we're going to go ahead and get started, you guys. We have about 27 people in here. Thank you all for joining us. This is really wonderful. This is a really special webinar. For those of you who aren't aware, this is our very first HAEA youth webinar. That means this webinar was designed specifically with our young patients and family members in mind. We wanted to give you guys more of an opportunity to participate, learn, in hopefully words that you guys understand. That's really the goal here. We have a special guest, Dr. Doug Johnston. For some of those of you who were in the teen program at the summit this year, Dr. Johnston was nice enough to join us at the aquarium. Some of you may have met him. He's very wonderful and has prepared a really great presentation to give you guys. So the way this is going to work is that, as I've already mentioned before, everyone's microphone is muted. So the best way to ask questions throughout this is going to be to use the chat icon at the bottom of your screen. You're going to click that button and it should pull up a chat feature, and you'll be able to use that chat feature at the end, hopefully to ask questions when we open it up for questions. We're going to try to keep this to about 45 minutes. I don't want to take up too much time. So after about 45 minutes, we are going to wrap it up and kind of close questions. In the meantime, I just really want to thank you guys all again. This is such a wonderful thing, and we're really excited to have everyone here. So without any further ado, I'm going to go ahead and introduce Dr. Johnston. Dr. Johnston, I'm going to unmute your microphone.
Thanks, Lisa.
Yeah. So, Dr. Johnston, do you want to maybe talk about yourself really quick?
Not really.
Okay. Okay.
but I'll just mention quickly that I'm in Charlotte, North Carolina. So we had a few snow days recently. But I've been in the HA space for about 10 years, and I'm in private practice here in town.
Wonderful. All right, Dr. Johnson. So I'm going to go ahead and share my screen so we can start the presentation. All right.
Cool. Thanks, Lisa, and I appreciate you moving through the slides, and I want to thank everyone for sort of coming out tonight. I know there's a lot of other things you could be doing, so I appreciate it. I've been sort of stuck inside the past few days because it's been snowing here, so thanks for joining me tonight. So this this lecture here was given over the summer at the Patient Summit, specifically for teens and children, with the idea that given the landscape of changes in this space over the past 10 years, everything's kind of changing. And this is a good time to talk about how to stand up strong and take this disease into your own hands. You can go to the next one. Okay. So the goal here is, this is pretty short, but the goals here are just kind of run through hereditary angioedema and what are the key things you need to know. Move on to talk about triggers of attacks and how things change during, over the years as a kid with HAE. And then I wanted to move on to a section I kind of called old school versus new school, because over the years I've heard many stories from patients, and these stories are changing. So the stories you may have heard from your grandparents or parents will not be the stories you tell your children, because things are changing so much. And then we'll sort of finish up on how to stand up strong and really change what this means to have HAE. Next slide. So most of you affectionately call this HAE, mainly because hereditary angioedema is just a long word and hard to say, so everyone kind of refers to it as HAE. But if you break the words down, the word hereditary just means it runs in the family, and the word angioedema is a medical term that means swelling. So it's simply, the term itself simply means it's a swelling condition that runs in the family. And some of the important points to really understand is that it's not allergic. And this will come up a lot, especially when you're talking to doctors, because doctors, when they see swelling, they often think allergy. But hereditary angioedema has nothing to do with allergy. And therefore, the medicines that are often given for allergy or often given when someone swells don't work for HAE. And that's because the cause of swelling, what actually makes people swell in HAE, is not an allergic trigger like histamine. It is something called bradykinin, which is a molecule that actually causes the swelling in HAE. And therefore, the medications that are used to treat it have to address bradykinin. And what's different about HAE compared to other conditions where people swell is that the swelling typically gets worse over several hours. So that's typical of this, where the point where you have the maximum swelling isn't going to be in 15 minutes. It's going to slowly grow, often over several hours. This is important because this gives you an opportunity to tell people you're swelling and treat as early as you can. And when I talk to my patients, I like to always get an idea of when they're treating the swell. Are they treating in the first hour? Because I usually think of that being a very good time to treat. If you can identify swelling and treat within the first hour, that's often going to lead to better outcomes. So what's important to have going forward is to have a treatment plan that you and your doctor kind of formulate, know what your medicines are and how to give them. But what we're going to move on and talk about is how to discuss HAE, specifically how to discuss it with people that are family or friends, but also when you speak to doctors, how will you describe this? Next slide. So I like to think of this like, how do you describe what's happening in your body? And I just oftentimes think of a waterfall when I think of HAE. And I like to think if the water makes impact on the ground with a lot of force, like in this picture, you're going to swell. Next slide. So what's happening inside your body is when in this waterfall is what's happening is these proteins that are setting off a chain reaction. And during an HAE swell, what happens in your body is this protein called kallikrein gets activated. And when that protein gets activated, the bradykinin gets released. Now, it's at the point when there's bradykinin that gets released in different areas of your body that will cause fluid to move from your vessels into your tissues. So basically, what's happening is fluid is just coming out of veins and accumulating in your skin. So what this bradykinin does is it basically just causes fluid to move into places like your face during a swelling attack of the face, in your hands and feet, and at times it can accumulate in your belly or even in your throat during a more severe throat swelling attack. Now, what your body has is this protein called C1 inhibitor. You may or may not have heard of this, but this is a protein in your body that's going to regulate the waterfall, and it's going to essentially put little wooden or rock shelves so that the water doesn't flow as fast and make impact on the ground as hard. And you can imagine that this protein, what it's doing in your body, it's basically shutting down those points that are causing trouble. So the C1 inhibitor, this protein in your blood, works in several places to prevent swelling. And some of the actions of this protein is to block the activation of this protein kallikrein, which in turn prevents the release of bradykinin. And if you keep those guys in check, then swelling won't occur. Now, there's several types of hereditary angioedema. In type 1, what happens is you don't make enough C1 inhibitor protein. And since you don't make enough of it, that the function of the protein isn't working so well, and you'll get random episodes where there's too much bradykinin and therefore have swelling. HAE type 2 will look kind of the same, but the difference here is if you do the test to see if you have this protein, you actually have the protein. The problem here is that the protein isn't working right, and therefore the effect is very similar. So patients with type 1 and type 2 hereditary angioedema will look the same. Now, if your parent has type 1, then you'll have type 1 and vice versa. Now, there are some people with hereditary angioedema that have normal labs. And it's in this particular case, we don't quite know where the problem in the waterfall is, but the effects are going to be very similar. There's going to be too much bradykinin that gets made, and there'll be random episodes of swelling. And we're slowly learning and understanding where the defects are in the body in this particular type of HAE. Now, what the medications are doing is there's many different medications that are available now to treat HAE, and there's medications to treat the actual attacks, and there's medications to use regularly to prevent attacks. But essentially what they're doing is they're working at different sections of the waterfall to help prevent the water to hit the ground hard, and therefore, in essence, what they're doing is they're blocking kallikrein and preventing release of bradykinin so that you won't swell, or so that swelling can go away. Now, hereditary angioedema has attack triggers, but these are not allergic triggers per se. They're just things that can kind of irritate the waterfall and therefore cause more bradykinin release. Next slide. Some common triggers of hereditary angioedema include stress, which is really what I feel is the most common trigger that I hear from patients. And this could be good stress or bad stress. So this could be you have a test coming up, or it could be that it's Thanksgiving and a lot of people are coming over the house. This is not necessarily negative stress, but it's just a stressful situation. Some other common triggers include what doctors call local trauma. So this is like injury to different areas of the body, and this could range from a sports injury. It could also be injury inside the mouth, for instance, from a dental procedure, or injury from a surgery. So what these can do is sometimes set off an attack. Sometimes repetitive activities such as running or typing can lead to a hand attack. And certainly there's many medications that vary from person to person, where some people might find one type of medication is a trigger for them, where other people don't feel that to be a trigger. However, there are two types of medicines that are almost always a trigger. One type of medicine is a blood pressure medicine called, or a family of blood pressure medicines called ACE inhibitors. Very few kids would be on these medications, but it's important to know that ACE inhibitors are likely to trigger attacks in HAE. And a common ACE inhibitor is a medication called lisinopril, and the generic names of these medicines all end in pril. The word pril. Another common medication trigger is estrogens, which can be used oftentimes in medications for birth control. But estrogens naturally occur in women, and women oftentimes can have a more severe attack after puberty because of this. So it's really critical to have someone you feel comfortable talking to about these things, because you always want to identify the attack triggers early. Next slide. So I'm going to move on to talking about HAE, and I'm going to tell you some of the stories I've heard from people in the past, and some of the stories that are now occurring in some of my patients because they now are gaining command of treating and controlling HAE. So one of the old stories I would hear is you'd have a person trying to explain to their friends what their disease was, and they would say something like, I have hereditary angioedema, I have HAE, and I swell and nothing works. And your friends hearing some but not all this story, and they hear I have HAE, and they're just confused. Next. They may not even understand what HAE is. And obviously this is kind of silly, but HAE or HAE, they're not even thinking about a swelling disorder. Next slide. Another story I heard from many years ago is people would learn as much as they could about HAE, and they would try to explain in medical terms to their friends what it meant. And then this person saying, hey, then the bradykinin gets cleaved from high molecular weight kininogen, and really your friends is zoned out at this point. And of course, we've seen people scare their friends away because of how they describe their disease. And these were some of the stories of old, before there were many treatments available, and people felt very isolated when having hereditary angioedema. But it's different now. Now there are many medications. People have a better understanding of it. And a lot of what I'm seeing is sort of a newfound command of disease. And in this situation, I've seen some of my teen patients have a lot of friends who help support them. And what they've done is they've often said, I have hereditary angioedema. It's a swelling disorder. It's unpredictable, and it requires these specific medicines, which I carry, but it's not contagious. And with my treatment plan, I have it completely under control. And what I've seen is some of their friends have been extremely supportive and have even come to visits or to lectures about HAE, which has been really nice to see. Now, what can also be tricky is talking to physicians. Next slide. Sort of the old school approach is, and some of the stories you may have heard from family members, is the story in the emergency room, where maybe it was your parent or grandparent were in the emergency room with a bad swelling episode, and the doctor thought it was an allergic reaction and may suggest using adrenaline shots or Benadryl or steroids. Next. Obviously, those medicines don't work for hereditary angioedema, and that would sometimes frustrate the patient and the doctor, because the doctor is confused what's going on, and he or she will go down the wrong path, and this becomes extremely frustrating for the patient with HAE. While all this is happening, unfortunately, these patients were getting worse, and the doctors were keeping the patients in the hospital a long time. Next slide. And some of the problems that would arise back then were the doctors weren't really listening to the patient. In this case, the patient's trying to say, please listen to me, it's not an allergic reaction, these medications won't work, but they weren't always heard. Next slide. And this would cause a lot of frustration and anger and distrust of doctors in the emergency room. But things have changed a lot since then. And now there is an increased awareness. It may not be perfect, but it's definitely getting better as physicians learn more and more about hereditary angioedema. And we're starting to see hereditary angioedema specific medications in emergency rooms. And this has led to improvement in the awareness amongst doctors. It's also, we've seen patients are better understand their own disease and can describe it better. And in this example, the patient says, I have hereditary angioedema and my swelling is caused by bradykinin and it will not respond to those medicines like steroids and antihistamines, and even epinephrine won't work. Next. Patients are now bringing their HAE treatment plans to show the physicians. And in this case, here's my treatment plan from my doctors. It provides information about HAE. It provides the medications I use to treat swelling attacks and how to administer them. And what we're finding in recent years is that the ER doctors think this is helpful, and it helps to, it just helps them make decisions, and it helps them to treat as early as possible. And you might get a different message now if you present it that way. And in this case, the doctor says, yes, I'm aware of hereditary angioedema. Thanks for bringing your treatment plan. You'll get better faster if we treat your HAE attack early, and let's get started. And while you may not have had that experience, this is what we're looking for when we go to the emergency room. And I think it's happening more and more. So a few tips I could provide just so that you can sort of take control of HAE with the message of standing up strong. And knowledge is power here. So the more you understand about HAE, the better. But understanding how to describe it to different people, such as coaches, your teachers, your doctors, your friends, is only going to help. Have a good understanding of your treatment plan. Know what medicines you use and how they're administered. Make sure you know the doses, because this is important. If you present yourself as really understanding, it definitely helps physicians. The key here is for you to own HAE and not to let it own you. Teach everyone you meet, including your friends and teachers and coaches, nurses, doctors, about HAE. Remember your parents' and grandparents' stories, but tell your own story of control and empowerment. Your stories will be different, and the stories you tell your children will be different, because the medications have changed and are still changing, and they will be very different in how they control HAE going forward. So with new therapies on the horizon, increased awareness from everyone around you, and the amazing support from the HAEA, you're going to have sort of a new empowerment and control of HAE. So I'm going to stop there and take any questions.
All right, so questions. I'm going to start with a question that we had submitted to us, Dr. Johnston. And
okay.
Everyone, if you guys have questions, use the chat icon so that you guys can use the chat feature to ask questions. But in the meantime, one of the questions that was submitted was, how does HAE change as you get older?
So about 50% of people with HAE will have their first swelling attack prior to age 12. In young children, oftentimes, and not all the time, in younger children, their attacks are less intense. So as children get older and you go through puberty, it's very possible that the attacks will become more intense and more frequent. But as an adult, these attacks vary from person to person, and they even vary over time. So everyone is extremely different. So it's really hard to know if your attacks are gonna get better or if your attacks are gonna get worse.
Is anyone typing in some questions that you might have? In the meantime, I have another one that was submitted. What advice do you have for a patient that has been diagnosed with HAE but has never had an attack?
So my advice would be to obviously know all about HAE, number one. Number two, you would want to have a treatment plan and a medication ready to treat a swelling attack if it were to occur. And I would do that even before you have your first attack. And I would also recommend really understanding what symptoms could occur so that if you do have your first attack, you kind of recognize it as an HAE attack so you can treat it early.
One of our participants, Stephen, is asking, what can I do as a brother to help my sister with her HAE?
So there's a couple of things that would be really helpful. One, I would make sure that you know that your sister can come to you or let you know at any time if she's unsure if she's having an HAE attack. Two, you would want to have a good understanding of the treatment plan and what medications are being used to treat HAE attacks. And lastly, you may even want to have a good understanding of what to do if she had a severe attack, such as a throat attack, and the importance of getting medical attention as soon as possible.
All right, we have another question. So one participant, Carly, is asking, she says that in biology, we learned about pedigrees and being a carrier of a disorder. However, I thought with HAE, you can either have it or you don't. With HAE, can someone be a carrier of this disorder and never show symptoms, then pass it down to their kids?
It's a good question. So HAE type 1 and 2 are what's called autosomal dominant diseases. So there are no carriers. So it's a dominant gene, which means if you have the gene, you have the disease. So the way that works is if one of your parents have type 1 or 2 hereditary angioedema, each child that is born has a 50-50 chance of getting. Now, if let's say 2 people have 3 children and none of them have hereditary angioedema, then the disease stops, and therefore their children will not have HAE. It does not skip generations, and there's not a carrier.
One of our participants is asking about danazol, because not all currently approved medications are available all over the world. He's asking, what type of medicine is it, and what are the side effects?
So danazol is considered what's called an androgen, which is essentially a male hormone. And these medicines, what they do is they kind of work in the liver to ramp up C1 inhibitor so that there's more C1 inhibitor around. Now, these medications have a lot of side effects, and the higher you go on the dose, the more side effects are typically expected. Now, they're male hormones, so this can be a particular problem in women who take these medications because it can cause such things as hair growth or voice changes, much like a man would have. Some of the other side effects that we often worry about with these medications is weight gain, problems with liver, problems with cholesterol, and an increase in blood pressure. So these medications were at one point in time all that was available in the United States to really treat HAE, but that has changed dramatically over the past decade and are really falling out of favor as a mainstay for treatment of HAE. It's also important to know that androgens, or this medicine, danazol, do not treat attacks. They are only used to help prevent attacks. So they're used on a regular basis and will not treat an HAE attack.
It's just one of the reasons why here in the United States, we are so lucky to have so many wonderful medications that are approved by the FDA here. We really are very lucky where we don't have to use some of these older kind of medications that have really strong side effects. So you all are pretty lucky. Let me see. Let me find another question here. I just had a question about kind of type 3. One of the questions I think that relates to that was, how can you get HAE if no one in your family before you has HAE? Is that possible?
So yes, one of the things that happens in HAE is there's about 25% of patients don't have a parent with HAE. So the question is, well, how'd that happen? And the answer is, during birth, what happens when you're at birth is that some of the genes actually kind of change and shapeshift. And if they change and shapeshift a certain way, then it may alter the gene for HAE, and therefore you'll be born with HAE. And once that person is born with HAE, then the rules then apply to their children, that 50-50 rule with type 1 and type 2. Now, Lisa, you bring up type 3. Now, we don't understand the type 3 as well, because it's an area where we don't have as much information.
And
so
to clarify, it really is HAE with normal C1 inhibitor.
Right, HAE with normal HAE with normal C1 inhibitor. We don't have a clear understanding of how the genetics of it and how it gets passed from person to person.
Let's see, someone was asking about testing, and if you are tested when you are on a medication. So if they're tested, so say someone is on a preventative medication and their C1 levels are tested, would those C1 levels still be decreased, and would it show as they have HAE, or do you understand what I'm asking?
So it sounds like you're asking if you're on a preventative medication, would it normalize the labs?
Right.
And oftentimes it does. So it would depend on the medication, but oftentimes it does. It can potentially say normalize the lab. So for instance, if you were on a preventative medicine, you might find that some of the tests we use, such as C4, would be normal, and that's possible. So that's really important, and really is something. One of the reasons why the recommendation is to see someone with experience with hereditary angioedema.
One other question that I'm going to pull that someone has already submitted was, does HAE only last? I know you kind of addressed this, but just to reiterate, does HAE only last for so many generations? And just to reiterate, if it doesn't carry to the next generation, is it possible for the disorder to die in the family?
It is possible for the disorder to die in the family, because every child has a 50-50 chance. So I know a family and of a person with HAE, and he had 2 children, and neither of those 2 children had HAE, and they were finished having children. So therefore, the children of those children will not have HAE. So the HAE in that family is done, because it doesn't skip generations.
Interesting. One other thing, I think we're kind of closing up on some of the questions. A lot of people are saying that no one else in their family has HAE. So some people are relating to that question. Someone asked about using
tranexamic acid.
Yeah, and I'm not familiar with that. So is that something that you want to touch on?
We don't use a lot of tranexamic acid in the United States currently, because of the amount of other medications that are available. These medications were predominantly used in Europe, and tranexamic acid was mainly used as a medicine to prevent bleeding. But in some studies did demonstrate that it could potentially be used as a preventative medicine for hereditary angioedema. So this would not be a medication that you would use to treat an attack. That's very important.
Just another thing that we've talked about before, Dr. Johnston, was in the case of having swelling in certain parts of the body that aren't visible. Sometimes there's certain ways to talk about that if you need to talk about that with an adult.
Yeah, so sometimes I'll tell some of my teenagers that they may have swelling in places they don't want people to know. So you can have swelling of the scrotum or swelling in your groin, and you don't want to necessarily have your whole class know. And I've often told them to tell the teacher or the nurse that you're having an abdominal attack, and then when you get to someone you feel you can trust, or a medical professional, you can tell them more about what's happening. So in an effort to get to a medical person, if you were in a classroom, for instance, you can certainly, I've told my teenagers to tell the teacher that they're having an abdominal attack if they felt uncomfortable saying they're having swelling in the groin.
I just got another question here. Go ahead, Noah. He's sending it to me via message. Is there anyone else? The questions are kind of slowing down here. So one of the questions that I just got is, should I be worried about playing sports in school?
So this is this really varies from person to person, right? So it varies based on your triggers. For some people, sports can be a big trigger of attacks. For other people, it's less of a trigger. We have lots of I treat many patients who are on treatment and they play any sport they want. So this is really more of a discussion between you and your physician based on you as an individual and how you, how severe is your HAE and what are your treatments and how well they work.
Awesome. I got another question. We're going to wrap up pretty soon here. Are they getting close to a preventative drug that would be approved for children? Do you know anything about upcoming research?
Yes. So there at the current time, there are lots of research with preventative medicine. You may have heard of a drug that came to the market recently called HAEGARDA, which is a type of C1 inhibitor product that's approved. That's currently approved in older children. And in the future, there will be other therapies. There's a injectable kallikrein inhibitor that is being studied in children, and there's going to be a study looking at an oral medication that may be studied in older children. So what will likely happen first is you'll see drugs probably get covered for 12 and up, because that's just how research does their studies. It's really hard to do HAE studies in really young children because their attacks aren't as frequent. So it's really hard to study preventative medications in young children. But as these medications start to get approved for older children, you're going to see doctors start to look at using those or studying those in younger children. So our hope is, as we see more medications like the ones being studied and some of the new subcutaneous C1 inhibitor products get used in older children, we're going to be thinking about these medicines and studying them when possible in younger children.
One last question, and I think this is interesting. It's something that I thought about. Can someone with HAE give blood in a blood drive?
That's a good question. I believe they can, but I am not 100% sure of that, to be honest with you.
I'd say you definitely want to let them know when you're giving blood what your situation is. And
remember, when you're giving blood, you cannot be on a blood product. So if you were on no medication, your platelets are just as good as everyone else's. So, but I apologize. I don't know the current rules on that.
I think that if you're on a blood product, they discourage you or
Right.
protect you from, and most of the medications that we do use
Are
blood products. But that's a really great question. All right, you guys. Thank you, Dr. Johnston, for joining us today. We really appreciate you coming in and sharing your expertise with us and answering questions. Thank you guys to everyone who joined us for this webinar. You are all amazing, and we're really excited to be offering these new engagement opportunities for you and these learning opportunities. Our goal is to do these quarterly. So expect more and keep your eye out for information about upcoming webinars that we're going to be doing specifically for you guys. If you have a suggestion, I'm open to suggestions. What do you guys want your webinar, these next webinars to be about? Most of you should have my email address. I'll type it in the chat box here. Feel free to email me, you guys, with questions. We are so happy that you joined us. And again, I want to hear from you guys. If you guys have any feedback, please share it with me. And in the meantime, again, Dr. Johnston, thank you so much. We really
Oh, my pleasure. Thanks, guys.
You're wonderful. Thank you. Thanks, everyone. We're going to close the meeting now. All right, guys.